And you can see my slides.
Yes, we can see.
So very good to see you again after your very successful interventional meeting in Antalya. We were very grateful for your hospitality, so it's good to meet you even from a distance. I want to say good morning to Achilleas too, your co-chairman. I'll just show a live in a box case of a TAVI. There's nothing spectacular about this case. It's just a day-to-day case that we do routinely in our lab and in everybody's lab. I just want to highlight some of the lifetime management considerations and all the routine adjustments we have made, us and other centers as well, to make the procedure safe and effective. So it's a 77-year-old female patient, diabetic on insulin with moderate renal impairment. There's a history of coronary disease, so this patient had a previous inferior myocardial infarction with a PCA of the right coronary artery, and the ejection fraction was somewhat reduced with a 40% with moderate pulmonary hypertension, and she was significantly symptomatic and HYGEIA class 3. There was significant aortic stenosis. You can see the numbers here, and the Euro score of this patient was calculated at 4.13%. So these are some of the features of the CT scan. You can see a tri-leaflet aortic valve with moderate degree of calcification, the speckles of calcium in the ascending and descending aorta. The anatomy is small, so the perimeter-derived annulus is 21.6, 21.2 the area, and the LVO2 is 20 millimeters, but the height of the coronary ostia is both okay, 15 and 13. This is the aortic tree. You can see there is a lot of calcification, especially on the abdominal aorta and the left iliac artery. The right looks a little bit better. Still calcified though, as you'd expect for a diabetic elderly woman, but the diameters look fine. And this is the anatomy of the cranial artery. So there's somewhat bovine, but borderline bovine. The right carotid is coming off at an angle from the innominus artery on the right. So clearly it's a relatively young patient, it's below 80. There is a known coronary disease, so likely to require further angiography, so small anatomy. So I have to consider all this. So our plan was to implant an accurate Neo2 size small valve. Because it's a supraannular valve, so it has favorable hemodynamics. There is the potential of easy commissural alignment, which helps a lot, both with the hemodynamics of the valve, but also with the access of the coronaries. And we plan to use cerebral protection device with this. The procedural planning would be the primary access from the right femoral artery. It is our routine to do a cut down on that, and we've been doing so for the last 3.5 years with great success, so we don't steer away from that. There is a right radial access using a sentinel protection, a left radial access using the pigtail, and the left femoral vein with a short wire to use the pacing from the LV wire. So we don't use any temporary wire for that. I don't know if there are any comments on the case or on the planning, anything you want to add, Theo or Achilleas, or any from the audience before I show the case. It's a short case, so it's not going to take too long of your time.
It's a little bit small annulus, and in the small annulus anatomies, usage of the both other supraannular valve and a balloon expandable valve, we will use a small valve. It looks like 21, or maybe if you've got an intermediate size. But in this case, the selection of the valve, I think, good because of the. But maybe we can ask about properties of the accurate neo, for example. I think you routinely use larger balloons. In that kind of anatomy, for example, will you use a larger balloon, or what will be your selection?
The plan would be to pre-dilate with a 20 millimeter balloon. It's a 20 millimeter LVOT, 21 millimeter perimetry diameter of the annulus, so just predilation with a 20, and then use a size small, 23 millimeter accurate Neo2. Now, being a supraannular valve, it gives you favorable hemodynamics, and it doesn't have the closed frame that you have in other supraannular technologies, so coronary access is feasible quite easily with this technology from above. And also you have I will demonstrate on the case how easy it is to perform commissural alignment. So
Yeah,
we do
this
that.
I will ask to you, yes.
Exactly.
Will you
So
do the
commissural
commission?
alignment is very, very easy with this valve, and I will show it in a case. It takes just 30 seconds to 1 minute to do so.
So I guess in what was asked earlier, I think the most important thing here is to keep in mind that this is a relatively young patient, and you're going to have to intervene in the coronaries at some point further down the road. Therefore, you know, I wouldn't agree more with the picking that valve, that specific valve. It has a very good profile and very good numbers to support a good coronary access after implantation. However, having said that, and just to be, you know, for the argument, sake of the argument, I would say that maybe a small balloon expandable valve will also do the trick. Although I wouldn't go there as my first choice.
And prosthesis-patient mismatch also is a very important small annulus to predict long-term mortality. And so in this case, I think it's a very good selection.
In the discussion
about... we were somewhat swayed away from using balloon expandable valves in the recent results of the SMART trial in the small anatomies, you see. So I think a supraannular prosthesis in this particular size would be my first choice. Of course, if you go to medium or large sizes, it's a different story. Then balloon expandable would definitely be a very good choice as well.
For the sake of the discussion about lifetime management, Vlasis, would you consider also the possibility of valve-in-valve possibility in the future for this particular valve? Now, obviously, the goal is now to get a new valve in there to work for this, to relieve the critical stenosis. But number one, would you consider the possibility of this valve that you're going to implant for valve-in-valve in the future?
And yeah, absolutely. There's good data that shows that a balloon expandable valve can fit easily in the frame of the Accurate Neo 2. That leaves you again the coronaries unaffected, and because it's a second valve, it gives you a relatively bigger area compared to two balloon expandable valves. Plus, you don't have the worry of the tall skirt of, say, a closed cell supraannular valve that could potentially create any sinus sequestration, any blockages at the level of the sinusotubular junction, etc. So the valve-in-valve option is there for this technology as well.
Would you also consider an intraannular self-expanding valve?
Yeah, absolutely. That would also work. That is a very, very good point, because you have an annular leaflet, short skirt, and then potentially you can have the favorable hemodynamics as well as the future access to the coronaries. That's a very good point, Michalis, I agree. So if you, in the interest of time, I can move on to the case. So hemodynamics are top left, our table is on the top right, and the fluoro you can see. This is Konstantinos Papazoglou pushing very elegantly the long sheath in. It takes for him about 5 seconds, but we trust him. We never had any issues with that. So the next step is left radial for the pigtail. You can see pigtail is moving in to get access. First, we'll do an injection to visualize the cranial arteries, just to show the anatomy in order to implant the Sentinel device. And as I said, we do that as a routine. I mean, you can argue whether, you know, this is absolutely necessary or not. You can argue about the data. I totally agree, but we have had some very impressive fishing elements out. You can see now the anatomy. It's sort of bovine. It's not 100% bovine, but there is a bovine element. So our practice here will be to push through the right radial artery along 300 centimeter wire, coronary wire, that will end up in the ascending aorta. And then over this wire, we will push the Sentinel device. You can see now the Sentinel is going in on the left. So the procedure is first to deploy the proximal basket, which is quite easily done. We have our anatomic landmarks, and then by flexing the distal basket, you can see there, we can rotate, and with some persuasion, the coronary wire will end up into the carotid on the left, I think in this particular case, we changed wire because the tip was a little bit damaged, so we just inserted a new wire. But that made it quite easy to go up to the carotid. Sometimes it takes a little bit of manipulation to do so, but usually it's not that difficult. See, the wire is going up, we're pulling the system, and then we're just pushing the distal basket. So once this is secured in place, then the next step will be to take our aortic root view by advancing the pigtail to the aortic root. And then once we're in position, we try to take a view that shows both cusps aligned. We only use the three cusp view, but we need to make sure that all the three cusps are aligned properly. We don't need to swing from the three cusp to the cusp overlap view for implantation purposes. We do that only to ensure commissural alignment. So that saves contrast and fluoroscopy with this particular technology. It makes it quite simple. Then the next step will be to cross the valve. And you can see here, we do that with a straight wire. Some people use a pigtail on that, but usually a straight wire, if we have taken the fluoroscopy, it doesn't take that long. You can see now the wire crossing in without any problems. AL1 goes in. Then we change with a long exchange wire coronary. For most centers with high volume experience, these are automatic maneuvers. And then after getting the exchange wire inside the left ventricle, then we put a pigtail, which you will see in a minute. It's very important to avoid papillary muscles, because papillary muscles will deflect the wire and will make the LV very irritable. For this particular valve, it's very important that we have a nice, comfortable position of the safari wire inside the left ventricle. And we need to make sure that the wire loop will be facing upwards. So you will see that. We'll take the gradient first. So here you can see there's a gradient about 30 millimeters of mercury. And then we're just threading the wire inside the pigtail. So this is the position of the wire. So you can see it's very important that the loop is facing upwards and the wire follows the outer curve of the ascending aorta. This is the position that you need to have when you implant Accurate Neo2. So now the next step will be to pre-dilate the valve using a 20 millimeter balloon under rapid pacing. And as I mentioned, the pacing, we don't use a temporary wire because these valves have a very low probability of having a temporary wire. We would only use it if we have a pre-existing right bundle branch block. So this is the balloon going in, and you can see the black clip will go to the wire, to the safari, and the red is on the venous sheath on the wire that is in the blood pool. So now we will pace at 180 beats per minute. And we will inflate. So we inflate. Okay. Pretty straightforward. And then we will implant the valve in a minute. So the valve is quite flexible. It follows the curvature quite easily without many issues. The sheath that we use is a 14 French and is expandable. So the valve is inserted using a little sheath, a little insertion aid that you can see in my fingers, in my hands. That takes a little bit of effort to expand the sheath, and then it follows all the way up to the arch and down to the root. Now in this particular situation, we need to make sure we have commissural alignment. So we looked at the three posts up there that if two are on the left and one on the right, we anticipate that we have to rotate clockwise in order for them in the three cusp view to be totally aligned. And what we do now is we move to the cusp overlap view and we rotate the handle clockwise so that we can see a free strut there on the right and two cells and two posts on the left. So this is as easy as it gets. It's very visible, and it takes just a minimum effort, usually a few seconds to rotate. And then we're in good position. We just implant so that this marker in the middle of the valve is at the bottom of the pigtail. Most of the times we pace at 100 beats per minute to minimize any motion, and then we just deploy the valve from the top to the bottom. So first we open the crowns. We just recheck the position, then we will open the arches that will center the valve and will make it stable. It's a process that takes a few seconds. Patients are usually tolerating that without any problems.
Is there any importance of the flashport position for the commissural alignment?
Correct. It is. We usually insert it at 6 o'clock. So by having it at 6 o'clock, it gives you 80 to 85% probability that you will end up in the commissural alignment. And then you can see the opening of the stent frame that is very fast, and then we just resheath the whole assembly, and then we take it out. Now you can see the three posts of the valve there. They're equally spaced in the cusp overlap, in the three cusp view. That having done all the work that before, it shows that we're commissurally aligned 100%. But in order to document that, we need to move over to the right side, to the areocaudal, to the cusp overlap view, and then you will see the two posts on the left side and the one post on the right side that confirms the commissural alignment. If it's the other way around, that means you're totally misaligned, and we don't want that to happen. Of course, having done all the procedure that we did before, all the steps, it's very unlikely that this will happen. But because it's a 60-degree rotation between one position to the other, to the full alignment, from the full alignment to the full misalignment, we need to take these steps. So first we take out the wire, we put a pigtail in. With this valve, and you can see the hemodynamics are great, no gradient and nice separation of the diastolic curves. It's very important not to lose your wire position in this valve, because if you want to recross, you need to take care, and you can see there's no PVL, you need to take care that you go through the valve and not through one of the arches, because that could potentially create problems if you want to post-dilate with a balloon. So it's one of the things that you need to take care. So now we're happy with the hemodynamics, and just for the sake of demonstration, we roll over to the areocaudal, to the cusp overlap view, and now you will see, I think I've seen it, yeah. So you can see here two posts on the left, one on the right, and that is a proof that we are commissurally aligned 100%. So I think pretty much this is the case. This is the removal of the sentinel. So after taking the pigtail out, we go up and then we just resheath the distal basket, and then they unflex the distal system and then resheath the proximal basket. And we always try to see what we captured. In this particular case, we captured this. So lots of white stuff, white clots or debris or, I don't know, calcium. So, you know, maybe nothing could have happened before if we haven't put the sentinel, but who knows, you know. That's the unknown of these procedures. So patient did very well, discharged on day 3 with an eventful recovery with single-digit gradients and no PVL. So thank you very much for your attention, and I'm open to discussion and questions.
Thank you very much. Thank you, Vilas. Excellent case. Is there any question from the panel and from the audience? I will ask one question for the alignment, commissural alignment. The system looks pretty flexible, and you can return it inside compared to the other system. Now, other systems are also focused on this point, I think, Vilas. What do you think about this?
I think it's one of the best systems to perform commissural alignment because the markers right now in this iteration of the device, and I know the company is preparing another iteration that probably will make it even easier, but in this iteration you have two clear markers. One is the posts that you can align before, and one is the free cell that when you have it on the right side in the cusp overlap view, you know you're commissurally aligned. It's very flexible and it's very safe to rotate. Even rotation over 360 degrees is acceptable. The main thing is when you reach to your position to let the system dissipate. So get your hands off the system and let it torque back so that there's no stored tension. Otherwise, when you open the valve, it will continue to rotate and then it will lose the alignment.
Thank you.
Okay.
Now,
Okay, I see there are no more questions. And I think we had a wonderful session. I would like to congratulate all the participants and the panel.